Well, that is truly the nicest introduction I've ever gotten. Thank you, Dr. Ramamurthy. I'm really honored to be here. I'm embarrassed that this is my first time in India, but I am thrilled to be here. I have so many friends. I have such respect for my Indian colleagues, and I've learned so much from many of my colleagues here in India. So it's really great to exchange information and be with you. I'm going to talk on a very different topic, which is about presbyopia correcting IOLs and setting up a framework of where we are. Well, how do we address presbyopia with IOLs? We can do it with monovision, with simultaneous vision, with accommodating IOLs. Monovision is actually something I use a lot. I'm a big fan. I like to target about -1 to -150 for the near eye and use an enhanced monofocal to give that extra depth of focus. And even if your patient tells you they don't really want it, everybody wants to be able to see their phone without glasses, pretty much. So that's always something you have to keep in the back of your mind. My approach to the patients is, of course, if the patient absolutely refuses it, I won't do it. But I will even try a contact lens trial to show them what it would be like to have or not have near vision. If they're undecided, I'll do the dominant eye first for good distance vision, and if that vision is excellent, and if the other eye, the vision in the other eye does not impair their distance vision, that tells me that their brain can adjust to having two different images, and I will do the other eye for near. And one other important thing is I don't take away near vision that's already present, and if someone's a lifelong myope, actually I often will make them bilaterally myopic to retain that near vision that they have so comfortable with for all their near tasks. But we have a lot of patients who are candidates and are asking for simultaneous vision presbyopia correcting IOLs. We use them because patients ask for them, because they can provide spectacle independence, and because they provide full stereopsis. This paper by Dan Dury in the American Ophthalmological Society showed that if you induced monovision about 1.5 diopters, you lose a little bit of stereopsis. If you go beyond that, stereopsis falls off quite precipitously. Presbyopia correcting IOLs also prevent falls, and I attribute another Chang, Daniel Chang, to this information. Daniel looked this article up in the Journal of American Geriatric Society and found that 1/3 of falls are attributed to bifocals. And in 2014 in the United States, there were 29 million falls, resulting in 27,000 deaths. So presbyopia correcting IOLs are actually really good for our patients if they can tolerate them, and they're candidates. So simultaneous vision IOLs, by which I mean those that provide more than one focal point, there are many optical designs. There's small aperture, refractive continuous that use some form of spherical aberration, refractive zonal, and diffractive. So we have a lot of choices. Well, small aperture choices are really in the United States. We have the Apthera IC8, and we thought this was going to take off and be a more commonly used, but actually it's been relegated really in the United States for off-label use in eyes with irregular astigmatism because of patient issues with darkening of vision and actually with some glare due to the small aperture and probably some diffraction around the edge. Spherical aberration, for positive spherical aberration, there are no IOLs in the United States that meet the EDOF criteria. For negative spherical aberration, we do have the RX sight lens, which I'll go into. And internationally, there is the CFE Miniwell Ready, which is interesting because it combines both positive and negative spherical aberration with a periphery that is actually a monofocal. So the light adjustable lens is very interesting because if you treat a patient with a light adjustable lens and aim to -0.5 to -2.25, it doubles the negative spherical aberration. And you see that red defocus curve there. You can see it actually extends the near vision up to about -2.5 to the 20/30 level. We confirmed that with our own studies using adaptive optics. So that's a good range of vision, and you can then do what we would call kind of micro monovision in these patients, and they can be often very spectacle independent with little or no glare. There's another RX sight lens called the RX sight LAL+, which is an EDOF, and it has a central zone that has a central increase in negative spherical aberration, and that differs from the standard LAL that you treat where the entire lens is changed, this is a central zone, but it does extend the near vision and gives patients increased spectacle independence. What about enhanced monofocal IOLs, which I know you have here in India? We have a couple of them in the United States. We have the IHance, which has a continuous power increase primarily in the center with negative central spherical aberration. And then we also have the Invista Aspire from Bausch & Lomb that has a base lens with zero spherical aberration and then central zone steepening. And these, both clinical and laboratory studies, for example, with the IHance, in this situation with the 3 millimeter pupils, show that you really don't have a decline in distance vision to any great extent, and you would get one more line of near vision in these patients on average. It's going to vary from patient to patient, but it's going to be particularly beneficial for patients with smaller pupils where they really can have the pupil come down around that central zone. And it enables one in one's practice to do a really interesting form of monovision, because the distance-corrected acuity and intermediate with these lenses is around 20/30-ish on average. But if you target minus 0.6, and that moves the curve over, the distance vision will drop to 20/25, but now you've increased the intermediate vision to 20/25, and your near vision can be as good as 20/40. And that can give a lot of spectacle independence, particularly when using electronic devices that, again, because of the brightness, will make the pupil smaller. What about refractive zone optics? Those that have a concentric design, and actually my slide is incorrect as I realize that, having talked to colleagues here in India. The Pure C does not have zones. It's a continuous change lens, so it really belongs in the prior category. But we do have the Alcon Vivity. There's a lens that's available internationally, the Lentis Comfort from Teleon, and we have the LensTech Clearview, which is a different zone with one half of it being distance and one being near. And the Vivity lens does offer the promise of very minimal glare. On this slide, you see a monofocal on your left, the Vivity on the center, and then the diffractive Symphony lens with a greater halo pattern. But the problem with it in my practice is that I just see a lot of patients that aren't happy with quality of vision with that lens, and that's a detriment. I think, again, with a smaller pupil where they're kind of using both zones at the same time, they lose some quality of vision. And I've had a hard time predicting who will like it. Now, the Johnson & Johnson Pure C lens, I've talked to some of my colleagues here in India. They found it to be a great lens. It gives quality of vision close to a monofocal with distance-corrected intermediate of 20/25 in the FDA studies, and very little starburst glare or other positive dysphotopsias. So we are eagerly awaiting getting that in the United States. The FDA, in their wisdom, made them repeat much of the study. So we're still holding our breath until we get this, and I think that's going to be a very useful lens. Well, then that takes us, of course, to diffractive optics, where the step height determines the percentage of light at each focal point, and the step spacing determines the magnitude of the add. And of course, there's light that's lost to higher order diffraction. What's interesting is you can address chromatic aberration with these lenses, because the refractive zone of the lens refracts blue light more strongly, but the diffractive ridges actually will refract the red light more, and so you can neutralize chromatic aberration. Whether this truly impacts patients' quality of vision, I think, is uncertain. So we have one diffractive EDOF in the United States, the Symphony, which is nice because it has very high quality of vision. It's devoted, of course, just to distance and intermediate, but you have to remember that these patients cannot expect to get good near vision. Sometimes they do, but you don't want to promise that. So there's been a lot of advances in diffractive technology, as I think all of you know, with the kind of lenses that have come forth, smoothing the ridges or echelettes, creating a larger landing zone so they're more tolerant to defocus, a violet filter in the J&J lenses to reduce glare, and designs to try to minimize the nighttime glare. And this is an example of high resolution lathing in the Johnson & Johnson lenses to get a smoother surface and reduce the glare that might be induced by those ridges and some irregularity of the surface. We have a lot of these in the United States. We don't have the AT Lisa. We'll have the fine vision lens soon. And you can see that we have a lot of choices, and I think you have a lot more here in India as well. Here's an example of a lens that is designed to give you a larger landing zone. This is the J&J Odyssey, which has about a 0.75 diopter landing zone for 20/20, which means you have a little more range of vision that you can get for distance and still have a good quality of distance with that. Another approach that's being used by Bausch & Lomb is to go back to the old apodization, as we saw with the Restore lenses, like the Restore 3 diopter, the original one, where the amount of light that goes is directed for distance increases as pupil size increases, thereby reducing nighttime glare. And there have been many other companies that have been producing these lenses to minimize dysphotopsia. The J&J Odyssey also has a lot of features for that, and I use that in my practice, and I found that the complaints of glare at night for this group of patients is the least I've seen with any of the models I've tried. Zeiss has a new one, the Alana. We have the Fine Vision Triumph, Hanita Intensity, VSY Trinova, and the Rainer Galaxy, which uses a very different sort of optical design. And all of these are designed to provide the best range of vision and minimize glare. And we have other interesting designs that have all kinds of little innovative approaches. So it's complicated trying to decide, I think, if you're with a practice. And for my own mind, I found that I do better if I have 1 or 2 designs that I use, and rather than try and kind of use too many different ones in terms of learning how to maximize them. We all know that there are limitations in diffractive lenses. You can't avoid physics. Simultaneous vision involves dividing the light. And here's a paper by Hayashi that showed with the Restore 3 diopter lens, if you add a half diopter of astigmatism, your distance vision with a Restore 3 diopter drops from 20/20 to 20/25, or even a little worse. We can see these are the point spread functions in a laboratory. If you look at the 0 diopters and then you go down to one line, you see the EDOF, and then you go another, the low ad bifocal, and then a high ad bifocal. That's the kind of glare that our patients encounter. There's also inevitably loss of contrast. The light is divided. This is again a patient from Genyang-Yoon, in which they did defocus curves, and you can see that the blue is the monofocal, and the EDOF, low ad bifocal, high ad bifocal are the other colors, and there is some loss of distance vision. It's inevitable as we divide the light. Okay, so that really then becomes an issue of safety for our patients in some respects. We've all seen our patients who have come in and they have normal looking retinas that 3 years or many years later look like this. They develop macular degeneration, and I think it calls into question whether we should be doing these lenses in younger patients under age 70. Should we prioritize quality of vision over range of vision? Obviously, many of our younger patients really desire these lenses and will benefit from them. And I think that what I've found is, even though there is some decline in vision if they experience macular degeneration later, they're so used to the lens and they're used to it that they seem to tolerate that quite well. So I am nevertheless cautious in selecting lenses if I have any evidence of macular pathology. And we have patients who come in with complaints, patients who come in with all these drawings, and here's another one. I have a lot of engineers in my practice, and they're happy to tell me how many rings they can see and how often that bothers them. You know, there are a lot of papers in the literature. I'll just cite one of them that kind of shows a very typical scenario for this. When you ask, this is a paper that compared monovision to the fine vision trifocal, and it asked if you experience glare halo often or all the time, 38% with a trifocal, 6% with monovision. Do they disturb your daily activities? 10% with a trifocal, 0 with a monovision. Would you choose the same IOL again? 72% for monovision, 76% for trifocal. And that's what we see in our practices. Most of our trifocal patients are very happy, but we do have unhappy ones that necessitate often exchanging the lens. There is neuroadaptation that takes place with these lenses. This was a very interesting paper where they presented patients with the old 3 diopter Restore with a low contrast target with glare, and then they did functional MRI. And they found that early on after surgery, it recruited 4 different regions of the brain But at 6 months postoperatively, only the middle frontal gyrus was recruited. And that change in the MRI was accompanied by improved glare symptoms, faster reading speed, and better contrast sensitivity with glare. So it is interesting how our brains adapt to it. And this long sentence basically said these patients adapted in a way that benefited quality and clarity of vision. Okay, so we'll have just a little bit to go. So here's a patient of mine, 79 years old. He's a widower. He lives alone. He got a symphony lens. He was doing very well. He loved it, but he complained of starburst. So I put a monofocal in the other eye, and he came back 6 months later, and what do you think he wanted? He wanted an exchange, which I did, and he was happy with a monofocal. Here's a patient, very kind of quiet, country, soft-spoken. I put an Odyssey in the first eye, 2015, great result, complained of glare every time he came to the office, so I put a monofocal lens in the other eye, and what do you think he said at 3 months? He wanted the Odyssey in the other eye because he'd gotten used to it. So these are the kinds of complex things we encounter. And I've done, here's a snapshot of exchanges I've done, and I did between July and December 2023, and you can see that I took out 9 multifocal lenses, 6 due to glare or starburst, 3 due to poor quality of vision, and 2 of them were my patients. So, what about neuroadaptation? So here I want to show you 3 images, pairs of images. This is a girl, you can see both images are the same. And what I'd like you to do is stare at the green dot for a few moments. Just look directly at the green dot, and you can, of course, you'll see that there's a foggy or a poor contrast, low contrast image on the left, a good, very hyper contrast image on the right. Looking at the green dot, now I'm going to change the slide, and you can see what happens. And I think most of you will realize you all neuroadapted to it. What we don't know is why don't all our patients do that, and can we train them in some way? Finally, just a comment about accommodating IOLs. There are a lot of them. There's the fluid vision lens that Alcon is working on. There's the Juvene lens, which is a 2-component lens that has an accommodating element that can be placed in the front. There's an Tia Vision, which has, again, an interesting design where the fluid is transferred with the action of the ciliary body, and a jelly C. These are just 4 examples of accommodating IOLs, and yet none of them have achieved, the kind of success we're looking for, but I think we are actually making progress. They're a long way from getting sorted out. They're bulky, they're large lenses to put in, and they're going to be large lenses to remove, and the long-term safety and efficacy, I think, still needs to be worked out. So it's a long path ahead to creating the perfect presbyopia correcting IOL. It's a fun time, though, for us because we have so many good options. And again, thank you for the honor of giving this talk.
Thank you very much, sir. So I'm not going to ask you the same rude question that I asked David. But what I'm going to say is you are in the cutting edge technology. You are leading the cutting edge technology. You're leading to what God gave us as a perfect vision, and you're leading us to that perfect vision, which is a very, very futuristic thought, very evolving. But thank you so much for being with us here, sharing your knowledge and your wisdom, which has been the most important part of this lecture. Thank you, sir. So let us rise once again for a standing ovation for Professor Douglas Koch.